information and misinformation on the web. So let me go through the history of osteopathy from its beginning. Osteopathy is known around the world mostly by its parts, I would say. There are some popular names that people know. Craniosacral therapy is a popular name that has its roots in osteopathy, myofascial release, muscle energy, and many other names. Many of these have their roots in osteopathic medicine from the States. The history of osteopathy. Osteopathy is not that old. Osteopathy started from this man, Andrew Taylor Still, who was an MD, an allopathic physician, and he was a surgeon during the American Civil War. In the mid-1800s, we had a civil war, and he had a regular practice of medicine. When I say regular, there was no, medicines were not really useful in those days. Western medicines, they were mostly poisons or they were fake. And surgery, you'd probably die from infection, if not bleeding to death. But this was the state of MD medicine at that time. In 1863, 3 of his children died from meningitis. He had a brother who was hooked on morphine, which would be like crack cocaine today. And so I'd say that medicine didn't really serve A.T. Still very well. And yet he chose to move forward in life and discovered what we call osteopathic medicine. He doesn't say he invented anything. He said he discovered it, which is important. It shows his humble roots that osteopathy was there. It's just something that he became aware of, not something that he invented. When I said that medicine in the middle 1800s in the West was mostly fake or it was poison, this is an example of things that were very prevalent in the time of A.T. Still. Snake oil. This is just a picture I took from the internet, but these were the types of things that were actually sold in the States. And we use this word in the United States. If something is fake, we say it's snake oil. Well, that expression comes from the 1800s when they sold bottles of stuff like this, and it was to cure everything in the world. So from this bottle, which is an actual bottle, you can see it's 50 cents. People were making a few pennies a day. This was 50 cents for this bottle. You can see there's a scary snake here, so it must do something really good. And if you actually read this, it says it relieves instantaneously and cures headaches, neuralgia, toothaches, earaches. One of my favorite ones here, dislocations. If you have a dislocation of L5, you wipe this stuff on L5 and I guess it fixes it. Now we can say this in the modern world and look at it and say this is silly, but in the 1800s, they didn't think it was silly. My favorite one is right here. If you're afflicted with deafness, wipe this on your ear and you're going to hear again. I love to show this slide, and it's so funny to look at and then think that people were so backwards at that time. How can you believe something so ridiculous? And yet we still sell snake oil today. And I'll give you an example. Light beer, low-fat ice cream, low-tar cigarettes. I love ice cream. I would love to believe that eating low-fat ice cream will make me lose weight, but it's snake oil. It's telling me what I want to believe, but it's not true. So this is what was prominent at the time of A.T. Still, and he said there has to be a better way. What he did was he was an MD, his background. He continued to research anatomy and physiology. And then he decided that this brand of manipulation that he was going to do, he wanted to give it a name to differentiate it from traditional MD medicine. And so he called it osteopathy in 1874. It's not really a good choice of words in my mind because I run into so many patients who go, oh, osteo, you must be a bone doctor, right? And myself, when people ask me these questions, are you a bone doctor? I say, yes, lay down on the table. Do you do craniosacral therapy? Yes, lay down on the table. I don't spend too much time with lay people trying to get into philosophical discussions of what osteopathic medicine is, because there's no short or simple way for them to understand it. I just want them to know that they're in competent hands, lay down on the table, let's see if we can fix your problem. With colleagues, yourselves, other therapists, yes, I will explain what osteopathy is. But to the common person, they're not going to understand. What they'll understand is if I treated you and I was able to help your problem, they're going to say, well, that guy, whatever he's doing, that's good. And if I was not able to help their problem, then they're going to say, well, that guy, he's terrible. Doesn't matter what name I have. So he traveled around Mississippi, and in 1892, he opened up the first school. This was the ASO, American School of Osteopathy, and he died in 1917. The next important person, historically, this is A.T. Still here. The next important person is this guy, John Martin Littlejohn. John Martin Littlejohn was some type of clergy in the Irish church, and A.T. Still treated him for some sort of throat condition. We don't really know what it was, but A.T. Still treated him, and he enjoyed the idea of osteopathy so much that he began to study it. In 1900, he opened up the second school of osteopathy in Chicago. And then later on, he returned to England and opened up the British School of Osteopathy in 1917, which is still there today. It's a very good school. And many of the schools throughout Europe can trace their roots back to the British School of Osteopathy. John Martin Littlejohn, to say a little bit more about him, is a very different person than A.T. Still. He graduated in 1900. He did lots and lots of research, and he wrote volumes and volumes of papers on his findings, and he wrote lots of protocols for different conditions. You should do this type of thing based on his experiences. And this is a very big divergence from actually A.T. Still, and I'll speak about the divergence in a moment. But what's important is that early on, they were seeing these findings, seeing these results, and then trying to explain it. But they didn't have the benefits of modern research facilities like we have today and modern facilities that we have in universities today. Now, these people were doing research sort of in the darkness by themselves. If you go to England, and you'll see there's many good schools there, and they all have different parts of osteopathy that they like. You'll find people that are more esoteric. You'll find schools that are more mechanical. They sort of choose the different pieces that they might like. But there are some fundamental differences here. One thing that I found a little bit amazing to me is, because I have been all over the world and all over the osteopathic world, is you will see John Martin Littlejohn's picture everywhere and references to him everywhere throughout Europe, almost to the exclusion of A.T. Still. And these were not the same person at all. A.T. Still looked at the body as a human, divinely created, wondrous machine capable of doing its own healing if we just understood the anatomy and physiology and tried to get them back to normal. John Martin Littlejohn looked at things more in mechanical terms. They both used mechanics to describe what they were doing, but John Martin Littlejohn wrote protocols for everything. Everything was mechanical. You have this problem, do this thing. What A.T. Still said was, you don't have to follow a protocol. You just have to understand how the body works and then create the technique based on your understanding of the body. It was a much more artistic view. It was not anti-science, it was pro-art. And we can speak more about that later. Osteopathy, A.T. Still founded all of his manipulations and his ideas of creation of manipulations on three philosophies. Number one, that the body is a unit. Two, structure equals function. And three, the body has its own mechanisms for repair. I'm almost 30 years in medicine. When I started in medicine, the idea of holistic medicine became very popular. Every doctor said they're doing holistic medicine, but you went to that doctor and they did the same thing as the doctor next door and the same thing as the next one. There was nothing holistic about it. If you had a problem with pain in your hand, they looked for pain in your hand. They didn't look for problems in the shoulder, the neck, the spine, or the whole body. There is a difference if your underlying philosophy is that you see the body as one machine with a set of sub-factories, if you will, rather than just looking at things in isolated spaces. The second principle, that structure equals function, means that if things are uh, normally created in a certain way with a certain structure, there must be some optimal reason for that. We could go further into that in other advanced lectures on biodynamics and cranial, that everything must be functional at each stage of embryology. So we try to get things back to what their natural stage was. And the third principle is that the body possesses its own mechanisms for repair and to restore health. If you don't believe that, well, you're really listening to the wrong guy on the wrong Zoom call. Medicines are great. I'm trained in medicine and I'm trained in surgery. And there's a place for medicines in the medical world. But the body, most of the time, we get sick, we get injured, we cut ourselves, we eat some bad food and get poisoned. Most of us, most of the time, get over it. Why some of us, some of the time, need some help? Well, we can make physical answers for that. We can make spiritual answers for that. But essentially, we were designed to survive here. And if you think about that, let's take something that we know will kill you, cigarette smoking. There's no mystery about this. You want to smoke a pack of cigarettes a day for 20 years? We know what's going to happen to you. And yet it takes 20 years. People don't start smoking a pack of cigarettes. It would be really unusual and bizarre to get cancer within 10 years. It's possible. It's also possible to get lung cancer and never smoked. But my point of this is that doing something we know is carcinogenic and harmful for you, it takes a while before you break your body down in most cases. Think of all the stuff that you have in your body that's actually duplicitous. You're born with two lungs. You can survive with one. You can survive with one kidney. You can survive without a gallbladder, without a spleen, without tonsils, without appendix. We can argue about how many testicles or ovaries you need to continue the species. So you were built to survive here, and that's what A.T. Still said. You were built to be healthy. You weren't built to need me or to need medicines, but there's times where we do need assistance. So these philosophies are the underpinning of osteopathy, and it makes a big difference in how we practice. We are not just a set of techniques. Some early techniques that we know Dr. Still did, some ideas. Everything was grounded in the philosophy. We know he did generalized types of treatments for general wellness. We know he did specific and direct and indirect types of treatments. In other words, you have one particular area that's hurting, let's look at that area, or let's look at it indirectly through other structures. We know he did high velocity manipulations, what people call adjustment, bone cracking. He did these types of things. He did different types of soft tissue without the names that we have today, because he was not in the seminar world. We know he did lymphatic types of treatments. An interesting thing to note about Dr. Still versus John Martin Littlejohn. John Martin Littlejohn wrote down everything and wanted everything to be replicated. And A.T. Still did not allow pen and paper in his classrooms. And it's not because he wanted to keep things secret or that his techniques were secret. What he wanted was he wanted his students to be able to be artists themselves. He did not want them to memorize techniques. He wanted them to create techniques. And that's a big, big difference. I heard this when I was in school. What I'm telling you now, I was told by my teachers. And then in practice, what I got was do exactly as I do. We say in the US, my way or the highway. So we're told to be individual, but actually not really. I'm being told to copy my teachers. But the founder said, no, you're free. If you understand the body, the anatomy, and the physiology, and what you want to change, you're free to practice as you like. I like this idea personally. I'm going to speak just about a few researchers because there's so many we could talk about, and there's such diversity that came in osteopathy. As I said, osteopathy, this is not that old. This is not 150 years old. There's, Ayurvedic medicine goes back, to time immemorial. Chinese medicine goes back. Egyptian medicine goes back. Osteopathy is a very new viewpoint, actually. And when osteopathy came in the field, some very important developments happened right away. One is women. At the time when A.T. Still began osteopathy, he didn't discriminate against women. And there were some very brilliant women that did research, and I'll speak about, that came out of the osteopathic profession. And this is a time when it was a man's world. The MD medicine, women were not admitted to that. But A.T. Still, from the very founding, didn't have these issues. And I think that's it's indicative of the heart of the founder. Within osteopathy, there's so many different modalities, different ideas, and people argue about everything. Osteopathy is like having the holiday time where you have the family to dinner, but Uncle Joe can't sit next to Aunt Mary because they don't like each other and they don't agree with each other. That's osteopathy. It's not about conformity. It's about a lot of different skills. Find what works for you and explore that skill. So I'll speak about just some of them that I found interesting in our history. One is this guy, William Smith. He was an MD who then became interested in osteopathy, studied osteopathy. When the X-ray machines first came out, he was one of the few people to have an X-ray machine, and he was trying to prove what was happening with regard to blood flow and tried to study these things. Of course, at the time when the X-ray machines came out, no one knew how deadly exposures to X-rays were. He did some studies that were in excess of 70 minutes long. At 70 minutes, I think you're going to glow in the dark after that X-ray's been on, let alone you'll have cancer. But they were trying to understand and prove the results that they were getting. Again, this is way before they had sophisticated machinery or the knowledge that we have today. Carl McConnell was another interesting person who was a DO and then went on to study and become an MD from homeopathic school. An interesting side little note about America. Homeopathy at this time was much more popular than MD medicine. And then there was political battle between the MDs and the homeopaths, and the homeopaths lost that battle. And then it became, it was mostly disappeared. It's getting more popularity again today, but it was a political battle. It wasn't about human wellness, it was about politics and money. Anyway, Carl McConnell, he described lesions in relation to structural anatomy. He did experiments with dogs and guinea pigs, trying to make different lesions and then trying to see what was happening as a result of that. How is that affecting the arterioles, capillaries, veins, and so forth? What sort of pathologies could he relate to what they called the osteopathic lesion? Louisa Burns, as I said early on in osteopathy, they welcomed women into the profession, and you'll find no one more outstanding than Louisa Burns. She wrote so many volumes on research. She did groundbreaking research on what happens at the motor end plate. Reasons why you just can't throw a stim machine on somebody who's been a quadriplegic and keep muscles healthy. Partly that research is due to Louisa Burns, and then much later due to a man we'll talk about named M.KORR. So her observation started with just the idea that the muscle tone can be more or less with contracted lesions, things that we take for granted today in our studies, and we know this was, back in the, we could say, the Middle Ages of medicine. They were making these discoveries. What happens to the capsular ligaments? Why are they thickening? Is it due to pressure? Is it due to lack of pressure? This is where all these studies began. Wilborn Deason, he did a lot of work actually also with Louisa Burns. She inspired many people to follow her as well. He looked at how the organs are relating to the spine and how spinal mechanics may affect healthy functioning organs. He did quite a lot of work with catarrhal deafness, and I find that very easy to treat with osteopathy as well. People that are deaf because they're congested, these are easy things to fix. And also he did a lot of work with regard to acute middle ear infections. And I find that an easy thing to deal with, and osteopathically speaking. If we go a little bit forward in time, there's some other people that became influential. On the left here is Frank Chapman. Frank Chapman did a lot of work with points that he found on the body that related to viscerosomatic reflex. He looked at how organs in dysfunction were showing up cutaneously and leaving markers in the skin that can be found in the soft tissues. In the middle is Dr. Sutherland. Dr. Sutherland is credited with cranial osteopathy. This is what we call it in the medical side. Cranial osteopathy is a very deep specialty. The watered down version today is what you see as craniosacral therapy that everyone with very little education is taking taking a little bit of instruction and calling themselves a craniosacral therapist. I said to you early on, when a patient says to me, do you do craniosacral? I say, yep, lay down on the table. I never got into the political battles of I'm an osteopath versus you experienced something from someone of little education. Because again, the patient doesn't care. They care only about, did you help my problem? Did you not help my problem? But the craniosacral world, they've all taken their information from, it all came down from this guy, from osteopathy, at least in the modern world, because people have been manipulating heads for thousands of years, long before osteopaths. But osteopaths have their certain viewpoint. I put also up here Charlotte Weaver. She did her own cranial work, her own body at the same time as Dr. Sutherland. She never gets any credit because she didn't teach it to other people. She didn't have a big following of people, but she had her own cranial ideas separate from Dr. Sutherland. They never worked together. Strap technique was another technique that became popular, which was a very, very ballistic type of high velocity, heavy-handed adjustment they were experimenting with. Post-isometric relaxation, which today we would call muscle energy types of techniques. Now, some other people, and again, I'm just picking a few out here out of history. From Philadelphia, where I started, Angus Cathy. Angus Cathy did a lot of extensive work with foot dynamics in societies that were not wearing shoes. Both him and Dr. Halliday, this is Dr. Halliday here, were trying to study the osteopathic lesion. And I'll get into that in just a moment. The osteopathic lesion is what A.T. Still said he was treating. And then later, that name got changed, and we're going to talk about that. So what is the osteopathic lesion? What is it that osteopaths are treating? Wilbur Cole, I find him fascinating because he did a lot of work at Kirksville, the original osteopathic school. And he came from a neuropsychiatry background and then tried to prove what was happening with Louisa Burns's work and did some work with her, looking at what sort of dysfunctions were happening in the spine. And there's a lot of very important progress has been made from the neuro and the psychiatric world into osteopathy. We don't have too much, I don't really have time to go into it in this lecture, but the idea of mind-body connection, these are intimately woven together. It's a new Western idea. It's a very old Eastern idea. The osteopaths are starting to look at in the Western world, the idea of the mind and body being connected in dysfunction. M.KORR, I mentioned him earlier. M.KORR was not an osteopath. He was a PhD. He had 3 PhDs, and he became so excited about the work he saw at Kirksville, and he worked to try and help the osteopaths prove what they wanted to prove. I was at his 80th birthday party in 1997, so I'm sure he's no longer with us. And at 80, he was one of the most brilliant people I've ever met. He helped to discover the idea of axoplasmic flow. Again, the work that was started by Louisa Burns, he was able to prove that. The reason why we can't keep healthy muscle alive only with electrical stimulation, because chemicals are actually coming at the motor end plate, which cease when the cord has been transected. So he was the guy who helped discover that. Also, he was able to elucidate the importance of lymphatics. Lymphatics, no one was looking at lymphatics until the 1950s. No one cared about lymphatics. What put lymphatics on the map was once they discovered that they could stage cancer by the lymphatics, that there was a big difference between stage 2 and stage 3 when it had gotten into the lymphatic system. Suddenly, all the eyes focused on lymphatics. And a lot of that work was due to M.KORR, and also he did a lot of work on the autonomic nervous system. Just a brilliant, not an osteopath, but a brilliant contributor who got involved helping to prove osteopathic research. Denslow was another person who was trying to prove things by EMG, as well as the profession is this disorganized, becoming a big disorganized monster. He was a big proponent in standardizing our terminology. And that was just happening when I was just entering school. You would have osteopaths using all kinds of different words to explain the same thing. And it makes moving forward messy when we have difficulty talking to each other. But one of the people who was really important in standardizing that and was very important was Denslow. He and also Kim KORR, I say Kim, that was his personal name, IRVIN M.KORR, the previous slide, they helped develop the theory of spinal cord facilitation, something that the chiropractors have picked up, but it came from the osteopathic world, this idea of the spinal cord being facilitated because of altered neural threshold. World War II. World War II was really important for osteopathy, because AT still started osteopathy and he wanted to be different than the MDs. As I said, MD medicine wasn't helping him, didn't help his family. He came up with a different outlook on things. In World War and in wars in general, something always happens. And what always happens is they need more doctors because suddenly they're at war. So what happened during World War II was the American the American government came to the osteopaths and said, you know what, you're so close to the MDs. If you would just study surgery and the application of medicines, we'll give you the same license. And that's what happened. It was good and it was bad. It's good because I have 11 years of postgraduate education. I've delivered babies, done surgery. I understand prescription medicines, and I'm an osteopath. I understand manipulation. So my knowledge base is very deep. It's good. The bad part, almost everyone I went to school with doesn't do any osteopathy whatsoever. They do medicine and surgery. So in America, if you go in the hospital, the person who delivers your baby, your psychiatrist, your surgeon might be a DO and an osteopath, and you would never know it because they don't do any manipulation. Outside of the US, it is a non-medical specialty, meaning they're not doing medicine and surgery, and they're not doctors. Anyone that you know outside of the US who's claiming to be a doctor of osteopathy, it is a false claim. Anyone and everyone who claims a doctorate in osteopathy, I'm telling you that now because there's so much misinformation on the web, unless they went to an American medical school, it is a false claim. So having said that, again, in the country of its birth, they're doing very little osteopathy. There's people like me, and I've had some excellent mentors, but mostly osteopathy is turning out people that are identical to the MDs as far as their practice. Around the world, and mostly who I educate are physical therapists, a lot of great work is being done as osteopaths without medicine or surgery. And personally speaking, because I've been doing this for a lot of years, physical therapy, this is the perfect. I'm not looking to undo anything you know by physical therapy. Physical therapy is perfect to study osteopathy because you know things that I don't know. You have backgrounds that I don't know about exercise and things we don't learn in medicine. And osteopathy is a perfect addition to what you know as a physical therapist. I found this to be, that's been my experience. Now I want to speak a little bit about osteopathic lesion versus somatic dysfunction. AT Still said he was treating an osteopathic lesion, and then later today it has turned into somatic dysfunction. Well, why? Why did the terminology change? AT Still's vision was that the osteopathic lesion was an all-encompassing problem that you had. It transcended everything. It involved your physical, your emotions. We could say spiritual, whatever that means to the different people in this room, whether you're Muslim, Christian, Buddhist, or have no belief system at all. Let's just call spiritual your deeper sense of self. So what AT Still said, that's what the osteopathic lesion was, something that was really affecting your life. Well, when we became licensed like the MDs said, we're not going to recognize this term, osteopathic lesion. You're not going to call something, name it after something from your profession that we don't know about. So they settled on a neutral term, somatic dysfunction. So it's a change of language, but from the change of language, it also started to change the schools. So I'm not just treating a somatic dysfunction. You're treating, someone comes into you with an L5 herniated disc who doesn't sleep well, who's got bowel problems because they have facilitated segments in their back, who has stresses from work, a family that gives them problems, kids who don't do well in school, and they're depressed. That's who your patient is. It's not an L5 herniated disc, and that's all we're dealing with. That's what AT still said. It was a very expansive and inclusive view of patients' problems. To say somatic dysfunction is a watered down, very, very uninvolved, simplistic approach of treatment, in my opinion. So, things merged. And again, a lot of things that have happened in medicine. What happened to homeopathy? Homeopathy got run down in the 1800s. It was all over politics and money. So osteopathy in USA, I have an equivalent license to the MD, which for me is very good. And as I said, for the profession, very bad, because people have just been attracted to medicine and surgery. So I see people that do use this concept, but they have different titles. They don't call themselves osteopaths. They have different professions. So the idea of osteopathy, it lives today with other names, and that's fine, because it's going to help people to be well. So osteopathy has gone around the world, and I think it's going around the world in pieces. It's broken up into different pieces. As I said, cranial, visceral, myofascial, different names that people know or that they're making up. A lot of it has its roots in osteopathy. Whether osteopathy gets the credit or not, I don't care. I just want the information should go around the world and it should help people. More recent names that I don't think you'll know these names, except for maybe you'll know Baral because his name is popular today. For visceral, everyone else here is dead. These are just some names. I don't think you'll know them. This was Robert Fulford. He was he was a student of Dr. Sutherland's. He was one of the greatest people I've ever met in my life. I didn't deify any particular people. Gee, I want to be just like this person. If I saw something I liked from him, I said, I'm going to take that part. Viola Fryman, she was another outstanding person. I said, I'll take a page from her book and I'll make my own book. Osteopathy is about freedom. This is Fred Mitchell Sr. from Muscle Energy, Dr. Johnston, Facilitated Positional Release, Counterstrain, Lawrence Jones, and many, many other names. Every month, someone will tell me, do you know this technique? And they give me some name, some new name that's been invented. And they say, show me something, explain it to me. They explain it to me, and it's very like something else I already know. So osteopathy is like painting. You have some major colors, and red, blue, and green. And then you have these in-between colors that are a little bit like this and a little bit like that. So the more you understand the body, you're able to just create what's needed. And that was the goal behind that. That is what AT still wanted for us. Where I learned what I learned, these pictures are way old because I don't look at all like this now. But I did these in 2005. Again, I don't think you'll know these names. Everyone is dead in this picture, except she might be alive still. I'm not sure. This was Phil Greenman. He might be a name that you know because he did a lot. He was one of the first ones to teach outside of the profession. He's written a lot of books. This is Bud Bernardi, another mentor of mine. You wouldn't know him. This Josephine Rockhouse, she did work with Beryl Arbuckle, who was groundbreaking in the 1940s, 50s, and 60s for children with cerebral palsy. And I last saw her. She's the only one who's near to my home. She's 2 hours from my home. So I visited her just before COVID, and she was 94. This was her husband. He died just a few years ago. Herb Miller. Again, these are not names I expect you know. They're not anybody from the seminar world. They're just masters. What am I calling a master? People that have been treating people for 30, 40, 50 years, they have gold. They might not have the proper words. They might not have the proper terminology. I have the proper words. I have the proper terminology because I'm teaching all the time. So I'm using the terminology. But if you're under their hands, they're masters. And what I'll say about that is, you know what? I'll say it at the end because I want to get through this slide first. What I've watched happen in osteopathy from where I started, from where it is it's gone to an evidence-based osteopathy and a systems approach, which for me, I think is really bad. It's gone away from its roots in classical osteopathy, going from holism to looking at body systems. I don't look at a body system. I look at the whole body and how it all works together. evidence. There's a big push for proving what we do. I agree with that. I'm fine with it. The one difficulty is proving skill. So if we say, um, does cranial technique work for this type of problem? It's hard to compare the technique versus the person applying the technique. And I'll give you that example in medicine now, because medicine wants us to say everything is scientific and can be scientifically proved. There's one area where they do acknowledge art, and it's surgery. And we all say about a surgeon, we say he or she's an artist. I got to get my gallbladder taken out. Yeah, you want this lady. She's an artist. And what that means is when she's got that scalpel in her hands, it's all dependent on how she's moving it. And that is an undeniable feature of osteopathy. It is an undeniable feature of manipulation. There are techniques that we can do and say these techniques help improve, and I think we can study it, and I think we can prove it. But the greater aspects of osteopathy, things that fall under the umbrella of esoteric medicine, cranial is never going to be proven in that way. Visceral technique will never be proven in that way. So, where does it lead? What's it going to do? Well, it depends on the individual. I'm all over the world. I've been doing this for a long time now. In the States, in Switzerland, in Korea, osteopathy is a good choice. It's another choice in addition to medicine or surgery, and it's a choice to consider before medicine and surgery. What I like about India and what I love about India is it's a good choice for your people here that have means and you're uber wealthy here. You don't need to worry about them. They can have this as a choice instead of medicine or surgery. But for the poor people and people who don't have access to medicine, which is many, many in your country, osteopathy and by the physical therapist might be the only choice that they're going to get. And osteopathy allows you, it takes you from the world of back pain, neck pain, shoulders, hips, and these physical things and neural maladies it opens up the door to general practice. And what I mean by that is, no, I don't have the cure for everything. I never laid any kind of claim like that. But with osteopathy, you have an approach to everything. So the person who comes to you with cancer, well, maybe we're not going to change that cancer, but maybe we'll change their quality of life. Maybe you'll get them sleeping better. Maybe you'll improve their emotions. Maybe you'll help their bowels to move better. Maybe they will live a little bit longer. You have an approach to it with osteopathy. So as a physical therapist, with an expanded view of being able to treat infections, different disease states, different neurological conditions that might have not had a traditional approach, you might be the only person to help that person that doesn't have access to flying to Europe, United States, and so forth. So I think osteopathy for us in the United States, it's a nice benefit. In Switzerland, it's a nice benefit. In India, I think you will save countless lives. I see osteopathic medicine as science blended with art. Absolutely. There's techniques we're applying, but we're applying it with an artful hand. Now I want to explain something to you that I think will be a concept you might not be familiar with. All right. This is an old osteopathic concept. It's part of the way I practice. For some people, it's useful. For some people, they don't use this concept. It's called the key lesion. So much of osteopathy is taught, especially since things have gone to a systems approach. Things are taught. I have a shoulder problem. What kind of things can we do to a shoulder? What kind of techniques can we use to a shoulder? It's taught like that. The way that I work is you come in, tell me your shoulder hurts. I ask about other pains you might have. I lay you down on the table and I disregard everything you told me. I actually do. And I look for what is called a key lesion. And then for my treatment, if you said my shoulder hurts, I absolutely am going to do things to your shoulder for two reasons. One, I'm going to find things wrong with your shoulder, and so is everyone else who's looked at you. So I'm going to find things and I'm going to try and change them. But I'm going to look elsewhere for things that might be contributory to your overall wellness or to the wellness of that shoulder. Things which you might not be complaining of, but I might be able to palpate. So let me explain to you the key lesion and why I think this is useful. I'm going to tell you a story. I'm going to tell you a short story here before I show you why key lesion works. When I did an undergraduate fellowship, was 1 year of manipulation before I graduated. It was a scholarship program in exchange to pay for my medical school. And the American osteopathic schools, because most of the osteopaths don't do osteopathy, they would award a scholarship to a few people in each class to do manipulation, hoping to keep the profession alive. So out of 200 people, I was one of 5 people that was awarded the fellowship. So during this year, I could do manipulation and I could explore everything that I wanted to explore. And one of my mentors was, he's now died 10 years ago, was named John Upledger. He became very well known for craniosacral therapy. A lot of DOs got very angry at him for teaching to people who are lay people. Having said that, I spent a lot of time with this man, John Upledger, and he was a great osteopath personally. He taught me Key Lesion and this idea, which I'm going to relate to you. The idea of Key Lesion is I find what's wrong in your body, I treat that, and that's what I pay attention to. So Dr. Upledger told me, he said, Steve, next time you go back to the clinic, he said, if you want to prove this to yourself, get a patient, don't ask them what's wrong with them. Evaluate them, find the key lesion, treat that, and then see how it fixes their problem, and you'll prove it to yourself. Okay, fine. So I go back to my clinics. I'm a student, but I'm an advanced student because I'm on the fellowship program. So I'm allowed to work sort of independently. I see patients in the family practice clinic. The family practice doctor doesn't do osteopathy, so I'm allowed to see patients under the guise of the family practice doctor. So I said, all right, I'm going to do what my mentor told me. I'm going to treat only the key lesion. So I told you the way I practice in my own practice is if your shoulder's hurting, I will touch the shoulder because I'll find things wrong with it. And this stops the argument of you thinking that I'm ignoring it. But in my process of learning key lesion, my mentor said, treat only the key lesion. So if you follow this situation, I'll describe to you what happened to me as a fellowship student. I am working in South Florida, which is mostly a Spanish-speaking community. And because they are Spanish-speaking immigrants, they don't know the difference whether I'm a student or I'm actually a doctor. I wear the white coat, I have a stethoscope. They're not really sure of the difference. So I come in to see this patient, a man in his 50s, and he doesn't speak English. His son is translating for him. And I tell the son, don't tell me what's wrong with your father. Don't tell me yet. And I didn't look at the chart. I didn't look at the complaint. I went in and did the key lesion evaluation, and I determined that L3 was his key lesion, his third lumbar segment. Now I asked the child, the kid, he's 15 years old. I said, what's wrong with your father? The father said, mi rodilla. In Spanish, that means my knee. Uh-oh. I found his low back is the problem, and he says his knee hurts. What do I do now? So I explain the idea of key lesion, and I say I'm only going to look at his lumbar spine, and the argument breaks out between him and his son. I didn't speak Spanish at that time, but I do know what the word idioto means in Spanish. It means I'm an idiot. So the father's telling the son that the doctor's an idiot. And I'm begging them, please just let me do this. They let me do it. I treated only his lumbar spine. I don't remember what I did, but I did techniques to his lumbar spine. I never touched his knee. He came back for the follow-up 5 or 6 days later. 75% of his pain is gone, 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 gone. Then I did some things to his knee, problem resolved. Now, if I have to go backward and say, how can I relate L3 to the knee? I can, not by a dermatomal map, but by a sclerotomal map. The ligaments and bursa go back to L3. So it's not hard to relate one part of the body to any other part of the body based on the more maps you know, the more education you know. It doesn't help you. We can relate one thing almost to everything else. So I did a few of these and I said, this idea is a really good idea. And so I do my key lesion on everyone. But if you said my back hurts, I'm touching your back. If you said my shoulder hurts, I'm also touching your shoulder. But the whole process will be beneficial. But what I learned is that key lesion is important, and it's been an important feature of how I practice. So this is what I keep in mind. The chief complaint, whatever they say they're there for, no matter how big or no matter how small that complaint is, that's the reason. That's the reason why they're coming to see me. It's the thing I have to fix. It's the reason why they're there. Um, I'll give you an example from my own house. My mother, every problem she has, it's like this. It's the end of the world. Everything is a 10. Nothing is a 9. Nothing is an 8. Everything is a 10. So I keep in mind when the patient comes in, if they say, I have this pain, I have that problem, whatever it is, it's their 10. It's their world ending. I also keep in mind if they came into the clinic telling me, well, my other doctor said this, my other osteopath said that, chiropractor said this, none of that matters to me at all. Why? Because if you're at my table, it means whatever that other person said, you're now on my table. So you still have the problem. So the fact that you're telling me what to do doesn't matter. I listen to it. I don't argue with people. I don't argue at all. I listen to it, and I'm going to look myself. So I'm going to give you the particulars of it. And unfortunately, because of the flooding here, I'm not able to give you an in-person diagnosis. We can have a lot of fun with this. One, I'm telling you a story, but if I can see you in person, I can prove this to you with some simple demonstrations of how this key lesion works, at least the way that I'm going to show you. The idea of key lesion is that there's some big problem in your body. And when I have heard other people talk about it, they talk about it as though it's this mysterious thing. We say in English, I'm looking for a needle in a haystack, or I'm looking for a grain of sand on the beach. You know, it's this impossible thing to find. No, it's not. It's this kind of needle in this kind of haystack. If it really is a key lesion, if it really is disturbing all of your body processes, I think every part of the body is pointing to it. From every study of medicine, every study of acupuncture, Ayurveda, homeopathy, someone's going to have a way to find this. It's not hiding from us at all. So one way to do this, and the way that I like to do it, some people call it arcing, and other people call it fascial glide, different names, but it's a palpatory event. It's not cerebral at all. And that's the part that is difficult to convert people to. And there's another in-person lecture, again, that doesn't really work so well over the internet, but so much we are not in the current space in time with the patient. Patient's telling you a problem, you're looking at someone else's x-rays, and you're already starting to filter out, and you're already deciding what to do, and you haven't palpated anything. What I'm doing is completely the opposite of that. I'm looking for a location. I'm not looking for a diagnosis, just looking for a space. Once I find the space, then I can get the microscope out and decide what the problem is. But I'm looking for a space. It's a completely palpatory event, and it happens instantaneously. The moment you palpate them and you're taking 10, 15 seconds of pushing, you're thinking, how does this fit? What did my teachers say? How does this make sense? You're not palpating. You're not thinking and palpating at the same time. So the origin of the key lesion can be physical, can be emotional, can be energetic, whatever that means to you. Energy means a lot of different things to me, but in this lecture, let's just say physical, emotional, or something more than that. The best way for me to try to describe this in a PowerPoint is that if I pick up your feet about an inch off the table and you're lying supine, and I move them a few inches to either side, I swing them along, not much, I just very lightly swing. If there was no restriction in your whole body, that sheet, the point at which it's anchored would be up here. If I think the key lesion is here, when I'm swinging your feet, if this was a sheet and we had a bed sheet across this whole, across a table, okay, and the sheet had a nail here and a nail here, and a nail here, we would swing the feet and we would feel that something is stopping it here. Or if the shoulder was a key lesion. That's what I'm trying to show. In person, it's very easy to explain this. This is the best I can do with the PowerPoint. And then because I like to do cranial, I'm going to back up my fascial glide with a cranial palpation. And what I'll do is I'll put my hands bilaterally across the body. And the whole process from swinging the feet to palpating the body is going to take me less than 30 seconds to find the key lesion. It's not a cerebral process. There's zero thinking that's happening. It's like when did you ever reach out and touch something and you thought you burned your hand and then you realized it was something that was icy cold? What your body responds to is temperature change. The fact that it's hot or cold is a cerebral thing that takes a few seconds to happen. The withdrawal reflex happens from radical difference of change of temperature. So I'm using reflexes here to palpate the body real quickly and say, in this example, what I'm trying to show you is, here's the key lesion. And I'm showing it by more circles. So as I palpate from side to side, I should feel differences in cranial rhythm as I get close to the dysfunction. As my hands get close here, the rhythm drops, it picks up, it drops. So the idea of cranial rhythm is it's sending out messages to the whole body and it's saying, here's the problem. So whether you do MD medicine, Ayurveda, massage therapy, whatever paradigms you're working in, everything is screaming, look at me, look at me, look at me. And so I'm using fascial glide and I'm using cranial rhythm is I think a very easy method for a global diagnosis. And there's many other methods, by the way. So by the idea of touching the feet and the knees and the hips and so forth, they're not magical areas. They're just bilateral listening stations. And for those of you that have done some cranial therapy, I'm looking for a decreased primary respiratory mechanism. I won't go much more into that. It'll get more complicated for our conversation. So I palpate each station briefly to look for differences in amplitude. I start at the feet, I go to the tibias, femurs, ASISs, and I do this because it's simple and it's non-invasive and non-threatening. Then I go to the lower rib cage and I'll go to the shoulders. I'm not going to go on someone's breasts or some area that's going to set off alarm bells for them. Then I'm finally going to end up at the head. And again, it takes me less than 30 seconds. If I find that the key lesion is on the left hip and they say, no, it's my right hip that's bothering me, it doesn't change it for me. I found what I found and I will go through the whole body, focus on the key lesion and your local complaint. I treat what I find. And since I've been doing that, my efficacy is about 75%. And what I mean by that is 3 out of 4 people I see, whether it's an easy problem or a hard problem, I'm able to either make it go away or make a difference such that some treatment from me was worthwhile pursuit. And in 25% of the people, whether it's an easy problem or a hard problem, I do a couple of treatments, nothing happens, the end. I tell them to go look for someone else. I haven't been able to help them. So this palpation, it is an important piece of the puzzle. I'm not ignoring the other studies that came. I'm not ignoring other medical opinions. I'm ignoring all of it to find my own opinion, and then I'll see where that fits into the bigger picture. So at this time, I am happy to take questions. And that is the end of that lecture there. And